Head injuries or head trauma may involve different things such as skull fractures, hemorrhage and edema, and direct injury to brain tissue. Injuries can be mild or they can be severe and life-threatening. In mild conditions, the brain usually just bounces around inside the skull a little bit and bruises the tissues. When it's severe or life-threatening, you have you have destruction of the brain tissue, and you can have massive swelling and increased cranial pressure that causes life-threatening injuries. So the first type is concussion, which is a minimal brain trauma. This is reversible interference with brain function, and it usually comes from accelerating the brain and its kind of excessive movement to the skull. So the brain actually sloshes around a little bit and then hits the side. It can result from a mild blow to the head or whiplash type injury. Often amnesia and headaches may follow. Recovery usually occurs within 24 hours without permanent damage. The problems increase when you don't fully recover from the concussion, and then you have another one and another one and another one, which can lead to some permanent brain damage that we see like in NFL players. A contusion is a little more serious. It's where we actually have a bruising of the brain tissue through a rupture of small blood vessels and some edema. A blunt blow to the head can cause possible residual damage. Closed head injuries are where the skull is not fractured in the injury, and the brain tissue's injury and the blood vessels rupture, but the skull's not the bones aren't broken. Extensive damage can occur when the head is rotated. Open head fractures involve fractures or penetration into the brain. Depressed skull fractures are when a piece of the bone actually gets displaced and pressed into the brain tissue and causes compression of the brain tissue. This also leads to a decrease in blood supply for the area and increases the intracranial pressure. Basilar fractures occur at the base of the skull, and you often see leakage, and cerebral spinal fluid can actually come out through the ears and nose. It may occur when the forehead hits the windshield, but the back of the brain, the back of the skull, base of the skull is what's actually fractures. Contracoup is where the brain is damaged on the opposite side of where the hit takes place because the brain bounces off the skull. And it may be secondary to acceleration or deceleration injuries. So moving too fast forward or stopping too fast, acceleration or deceleration. So this is a contracoup where the skull hits here and then it bounces off in the back, and you can see it hits in the back when you go backwards. So a direct injury and then a contracoup. Both can happen at the same time. Here's an open head injury with a depression fracture where the brain actually pushes the skull down into the brain. Primary brain injuries are direct injuries of the brain tissue through either laceration or compression. It can result in rupture of blood vessels, or damage the cerebral blood vessels, or damage from the rough or irregular inner surface of the skull. And it also can be when the lobes move against each other in different directions. Those are direct injuries. Secondary injuries occur from things such as cerebral edema, hemorrhage, hematoma, cerebral vasospasm, infection, and ischemia. So these are secondary injuries that may occur from head injuries. They can lead to other things like hemorrhage, hematoma, and these other problems. So we can see the possible effects of a head injury. So the primary damage is going to be that skull fracture. It can go and press down, and it can lacerate the brain tissue underneath. This leads to tissue damage and bleeding. And result, intracranial pressure increases, ischemia, necrosis, and loss of vital functions. A contusion is edema and has some minor bleeding. If we have brain motion, The brain rotates and it causes a shearing of the tissue where the tissue tears. Or we can have additional contracoup injuries, both of these tissue damage and bleeding, leading to intracranial pressure and then ischemia and loss of function. Now, those are all primary. Then if we have any secondary damage, so let's say there's blood vessels that are broken, there's inflammation from the inside of the injury, there's a hematoma forming, possible infection from the injury. So these are all secondary damage that come after the initial damage or secondary to the actual trauma. Okay, and they can lead to the same thing, and loss of function. Trauma to the brain tissue. This actually causes loss of function in the part of the body that is controlled by that area. So this is more of a localized function. There's cell damage and bleeding that leads to inflammation and vasospasm at the injury site, which can lead to ICP and intracranial pressure increased cranial pressure or general ischemia and dysfunction. Some recovery may occur and have some scar formation tissue present. A hematoma is going to be a blood clot inside the brain. Its location is going to be described, classified by where it is in between the meninges. So is it subdural? Is it epidural? Is it between the arachnoid, subarachnoid level, or is it going to be in the pia, subpia area? So you can see the different, couple different examples. This is an extradural or epidural hematoma. It's outside the dura mater. Here's one that is subdural, which is where it's in between the dura and the arachnoid mater. And here you can see one that is, let's see, intercerebral, which is actually inside of the brain tissue. So that's how they classify them. So we can see here epidural hematoma. It results from bleeding between the dura and the skull. The signs arrives within a few hours of the injury. It's going to probably increase the intracranial pressure. The subdural is in between the dura mater and the arachnoid mater. It can be acute, which means it's showing signs and symptoms, or it can be subacute, where you don't know anything's happening. It's below that threshold. And if it tears, the cerebral spinal fluid may leak into that space, and cause additional pressure. Typically, the hematoma will disintegrate with 7 days of post-injury. You do have to worry about increased cranial pressure at these events because the blood, when the clot breaks down, hemolysis, it can increase osmotic pressure. A subarachnoid hemorrhage is in the area where the CSF usually is. It's associated with traumatic bleeding from the blood vessels at the base of the brain. This is where the blood often mixes with the CSF, so it's maybe not going to form like that traditional hematoma blood clot. The blood mixes and it's going to be spread out through the whole entire CSF, and it's going to irritate that tissue, causing probably some inflammation and problems. And then the last one's intracerebral. This is actually in the brain tissue, and it often results from contusions or shearing injuries, and the symptoms may develop several days after injury. Here's a subdural hematoma. Okay. All types of hematomas lead to localized pressure in the adjacent tissue, and overall a general increase in intracranial pressure. Often the causes in young adults are sports injury, automobile and motorcycle accidents. Falls are common causes in any age group. So falling and hitting your head. You look for focal signs, which are the local signs of in a motor or sensory depression. General signs including of the intracranial pressures include things like seizures, which can be focal, which are localized seizures, or they can be generalized of the whole body. Cranial nerve impairment, Otorrhea or rhinorrhea, which is where the CSF leaks out of the ear or nose. Otto is ear, rhino is nose. Fever, which is going to show some systemic issue through hypothalamic impairment or systemic or cranial infection. Head injuries are typically diagnosed with CTs or MRIs that can determine the extent of the injury. Treatment with glucocorticoids can decrease inflammation and edema. Antibiotics reduce the risk of infection. Surgery may be necessary to reduce intracranial pressure, increase cranial pressure, and blood products and oxygen may be used to protect the remaining brain tissue. Then moving forward to spinal cord injury, often results from the fracture or dislocation of the vertebrae, where compressive stretches or tears the spinal cord. Cervical spinal injuries often result from hyperextension or hyperflexion of the neck with possible fracture. So whereas it actually goes back too far or goes forward too far. Dislocation of vertebrae may crush or compress the spinal cord. Compression causes injury to the spinal cord when great force is applied to the top of the skull or to the feet. So we can have some compression, like if we fall from a building and land on our feet really hard, it's going to compress from the head to the tailbone, and it's going to compress that spinal cord. So this is a hyperflexion of the vertebrae during an automobile accident. And you can see that the spinal cord is injured here, and the vertebrae is kind of drawn forward and bulging out here. It's causing compression on the spinal cord. Hyperextension, you can see right here. So it's putting a little kink right here in the spinal cord, and it's compression now. This is a compression injury, so all the pressure is going down and it's pushing down, and this vertebrae is fractured, and it's causing injury due to the spinal cord down here. Classification of vertebral fractures include simple, where there's a simple line break; compression, where it's crushed or shattered; wedged, when we displace a section of the bone like a wedge shape; and dislocation, where it's out of its normal position. Damage from spinal cord injuries can be temporary or permanent. Some axonal regrowth may occur, which is where if the neuron cell body is whole, the axon can regrow. Okay, so it can provide some regrowth. A laceration of the nervous tissue by bone fragments usually results in permanent loss of the affected tracts. Complete transection or crushing of the cord is usually irreversible loss at and below the level of injury. Partial transection or crushing can allow some recovery. Some of the problems that go along with spinal cord injury are bruising. Bruising usually spreads out from the side of the injury, and so the injury initially seems to have more damage than what it really is, because the bruising is reversible. If blood flow is lost, ischemia and necrosis can lead to permanent damage. Also, the release of some norepinephrine, serotonin, and histamines can cause vasoconstriction of the area and reduce blood flow in the adjacent regions. Assessing the dermatome map, which is the levels of the spinal nerves and what sensory parts of the skin they innervate, can determine the damage and the degree of the damage for the recovery. And so you can see here some dermatomes, and it tells you which spinal. So cranial nerve 1, cranial nerve 2 is the top of the head and the back. Cranial nerve 3 is the neck. Cranial 4 is up here. Cervical spinal nerve 1, 2, 3, 4, 5, 6, 7. You can assess. Here's our thoracic spinal nerves, lumbar, and then you have your sacral down here. And so the different areas, different dermatomes, where the pain is, where can they feel can determine what level was the spinal cord damage at. Spinal shock is the initial period after the injury where a great deal of the spinal cord loses its function, greater than the part that's permanently damaged. And during this period, the autonomic nervous system reflexes are usually absent, and the conduction of the impulses ceases. The recovery of this initial spinal shock depends on how much bleeding and surgical intervention needs to be done. As the inflammation and the chemical storm kind of subsides, the damaged tissue is removed and the scar tissue forms. The reflex activity that is controlled by the reflexes below that site of injury can resume. So the spinal reflexes below the injury can resume, but typically you see no communication between the upper level part of the spinal cord in the brain to the lower, but the lower level can resume some spinal reflexes. So the higher level control from the brain is lost. So here's a cervical injury, and we can see during the spinal shock immediately followed in the injury, all normal function above the level of inflammation. So the inflammation is the red portion that's spread out, so everything above that can be fine, but this area is going to be impaired near the inflammation. Then, and typically the reflexes down here are going to be blocked temporarily. So we're going to see things like no reflexes like flaccid paralysis, no sensation, urine retention, low labral blood pressure, sensory stimulus blocked at the spinal cord entry point. Then, over time, the inflammation goes down and continues to function fine at the brain level. There's still no information being passed up past the site of the injury due to a total blockage. But you will see that there are reflexes present, and you see spastic paralysis, which is that contraction paralysis due to the sympathetic kind of some of the spinal cord communication to the arms, lungs, legs, and trunks, but there's no control from the brain. Down here you see a lumbar injury, so there's no function at the level of injury, but you can see reflexes are present below, no sensation, no communication up to the brain, and then you can see normal function in the upper body. So with these spinal cord injuries, it's important to realize that you have the initial spinal shock, and then you have recovery and recognition, and number two after that, you have recovery and recognition of the extent of functional loss. So initially, all the neurological activity pretty much stops below the site of the injury and slightly above, with no reflexes present. Then after the injury, and this may go on for days or weeks, with this flaccid paralysis, sensory loss, and absence of reflexes. Then with recovery, you see the reflex levels begin to activate below the site of the injuries, but there's still no impulses from that specific area damaged. And we even can see hyperreflexia occur because there's no dampening down from the brain. Voluntary motor activity and sensory impulses are blocked at and below the level of damage. Many injuries are incomplete, and permanent damage varies between individuals. Some different terminology: tetraplegia is paralysis of all four extremities. Paraplegia is paralysis of the part of the trunk and legs, lower part. Ipsilateral paralysis and contralateral loss of pain and temperature sensation depends on the point of discussion, which is the damage and the location, where it's either the same side of paralysis or the opposite side with the sensation. With spinal cord injuries, you may have autonomic dysreflexia, and this is because the brain is no longer in control. So you may have what's a massive sympathetic reflex response, which is over and above normal sympathetic response. So something stimulates the sympathetic response, and it cannot be controlled by the brain. So some kind of stimuli could be infection, general stimulation, or other stimuli, and it doesn't get all the way up to the brain, and the spinal cord kind of sends out this massive sympathetic response. When this happens, it can lead to increased blood pressure, okay, sympathetic fight or flight, vasoconstriction below the injury, okay, vasodilation above the injury, and tachycardia. And all that stuff is really going to cause some really funky things to happen inside the body. So you can see that there's just this sympathetic storm taking place that cannot be controlled, where you see things like high blood pressure, headache, visual problems. Let's see. And we're unable to kind of calm everything back down to where it needs to be. Okay. Complications of spinal cord injury include things like urinary tract infections due to the retention of urine, pneumonia, which because of difficulty breathing, skin breakdown, with pressure ulcers, spasm pain, and also depression. Treatment includes rehab, immobilization, and treatment and rehab begin at the time of injury. We want to immobilize the spine, maintain breathing, and try to prevent shock. Hospital traction and surgery. Traction is going to try to put the bones back in alignment in surgery, which will relieve pressure in paired tissues. Glucocorticoids will reduce, or steroids that will reduce edema, inflammation. Ongoing care to prevent complications. Okay. Then we go to, this is another spinal cord issue, herniated intervertebral discs. These are the discs that are in between the two vertebrae, and they act as cushion. So what happens is there's a protrusion of that disc, the nucleus pulposus of that disc. It protrudes out of its normal capsule, and the capsule develops, and it can do gradually or by aging or obesity, and then it weakens and it pushes out onto the nerves. So it impairs the sensory motor or autonomic function. The most common locations are the lumbosacral disc, and even though some herniations involve surgical disc. If the pressure is prolonged for a long period of time, severe permanent damage may occur. And so we can see that nucleus pulposus, the outer capsule is torn, and it herniates out, and it pushes onto the spinal nerves. Okay, the spinal nerves. And then that's going to reduce, it's going to cause pain and reduce sensation and cause problems with the sensory and motor output through that spinal nerve. Predisposition to herniated discs include degenerative changes in the intervertebral disc due to age, obesity, metabolic changes. Herniation usually caused by trauma or poor body mechanics. The signs depend on the location and extent of the protrusion. Most effects are unilateral, meaning that if it bulges on the left side, it affects the left leg and the left calf. If it bulges on the right, it affects the right leg. But large protrusions can affect bilaterally both sides. The diagnostic tests include myelography with contrast dye, CT, and MRIs. Treatment: reduce weight bearing, rest is needed, application of heat, ice, and traction, drugs to release muscle spasms and pains, physiotherapy, and occupational therapy. In severe cases, surgery, which are laminectomies and discectomies. And kind of last stop is through a spinal fusion, where they're actually going to fuse the two vertebrae together.